This presentation and the following one will look at craniovertebral instability. This one will look at the pathologies of the condition, and the following one will look at the assessment of it. Okay, so let's look at stability first. Looking at the anterior view on the left, there's the anterior long ligament, the anterior atlanto-occipital membrane, and the anterior atlanto-axial membrane, and then of course the joint capsules. This is pretty much it from the front, but it's fairly substantial. The superficial look at the posterior membranes, and what you can see there is it's got more to it. That there's a posterior atlanto-occipital membrane, the posterior atlanto-axial membrane, the joint capsules, and then underneath that is the tectorial membrane running up the back of the vertebra and the back of the dens, and then inserted into the foramen magnum. Taking off the tectorial membrane, and underneath there we have the cruciform ligament, which consists of the transverse ligament and then the vertical part of the cruciform going from the axis over the dens and then into the occipital membrane, and then you can also see the two alar ligaments sitting there. So these ligaments and membranes all form the stability of this joint. Dynamic stability is of course maintained mostly by local stability anyway, by the posterior suboccipital muscles and the anterior suboccipital muscles, and these do much the same as multifidus does in the rest of the spine. So these are basically stop too much sliding between the vertebra when the big muscles work on the occiput and on C2. All right, let's look at the cause of this. Congenital is a big one. Down syndrome being first among these rules. You end up with microdensia, small dens, or a disengaged dens, an ossicle rather than the tip of it. And this is also odontoideum. Now, there is some debate going on now as to whether this is congenital, whether it's traumatic with unhealed dens, or whether it could be either. My guess is it's probably going to be found, like most things in there, it's a bit of both actually. But the big congenital condition that causes is Down syndrome, of course, and there's a fairly high incidence of Down's children and Down's adults, of course, with these defects, and they tend to come to light only with trauma, minor or major trauma, that produces problems. I read somewhere that when they've looked at flexion extension x-rays in Down's children, there's no higher incidence in Down's children than any of the cohort, whereas in Down's adults there is. And what it may be is that Down's children are stable up until the time you start getting degeneration in there, and then it all falls to pieces after that. Either way, you have to treat a Down's child, unless you know differently, as having this problem, and don't do anything that may disturb the problem if it does exist there. The incidence is reasonably high. I forget what it is, but I believe it's up to about 50%. Of course, that depends on the study you read. Trauma. Everybody thinks about transverse ligament when the neck's traumatized and that gets torn. It actually doesn't. They're very, very rare. Isolated tears of the transverse ligament are extremely rare. They tear sometimes when the dens fractures, but in that case, you've almost certainly got an unstable fracture, and that will never walk into your clinic. So when we look at fractures, these are potential instabilities because the dens is undisplaced for the most part. Otherwise, the patient would never get to you. Alar ligament tears do occur, and they're considered a rarity. However, there was an article which specifically looked at alar ligament tears in a radiology journal by Radenoff, I think it was, and they made no mention of it being a rare thing. So what may make it rare is the failure to look for it clinically. There's no way of knowing whether it's rare or not. And then, as far as diseases are concerned, the systemic arthropathies, pretty much any of them, rheumatoid, ankylosing spondylitis, these were the two that were mentioned in Sharp-Purser's article, but gout, pseudo-gout, and many other of these systemic diseases can do it, psoriatic arthritis and so on. And then the other disease that comes to mind is Grizzle's disease, which is a weakening of the ligament and or degeneration of the joints between the dens, the anterior articular atlas and the articular surface of the transverse ligament. So these become thinner, the ligament gets a bit more pliable, and so you get these instabilities set up. Mostly you'll see these in children. Every now and then an adult will have idiopathic instability here, which may be due to Grizzle's. It looks like though the infection actually tracks backwards from the upper respiratory tract via the pharyngovertebral veins and then affects that whole area and makes it unstable. So types of instability, there's an ARF, Atlanto-axial rotary fixation. This is actually a partial dislocation of the joint, not our subluxations. And essentially what happens is the C1 actually misaligns with C2, so it slips on one side and it pivots around the more stable of the two sides. So you get a rotation and there's a separation between the arch of atlas and the dens as it does so. These are not considered instabilities simply because they're fixed, so they're not unstable at the time. Obviously when they're reduced, or they reduce spontaneously, then you've got an instability there. But actually, while they're fixed, it's not considered instability. And if you do flexion, extension X-rays of these things, you won't see anything. These are often caused by very minor trauma, and one of the common areas we get in it is actually after surgery for tonsillitis. So the chronic infection from the tonsillitis actually destabilizes this area, from the tonsillitis destabilizes it, and then when you have an anaesthetic for any reason, actually I'd say surgery, for any reason, for tonsillectomy I suppose, then the patient wakes up with this torticollis. But it is a torticollis, and we're going to talk about torticollis in another video, but adolescent torticollis is fairly common. Whether you see it or not is another matter, but it's actually a fairly common disease, and you have to wonder how many of these are actually atlanto-axial rotary fixations. Fractured dens. It is fairly common with high energy traumas, fairly common, and I think it's the most missed spinal fracture, major spinal fracture there is. So be careful, even if the patient's had an X-ray, you need to be careful about treating somebody who may have a fractured dens. So look at the clinical signs and symptoms rather than the absence of a positive X-ray. Osteodontodium is certainly a type, and we've got some pictures of that, and it's difficult to know how you're going to find, or suspect they've got one, unless they've got something like Down syndrome or Hutchinson syndrome, or a history of trauma with ongoing pain afterwards, and that may explain it. I did know a girl who was on a physiotherapy course I was teaching, and a few months before she entered school, she had a car accident with severe pain in the neck. They x-rayed her, it was all negative. Pain went away, but she couldn't turn her head at all to the right. It's completely gone. Couldn't turn it. So she gets to school, and of course, what do? Well, we've got to get that movement back. So they give her exercises to bang away at this this lack of movement. Anyway, the pain got worse and worse and worse. So they did another X-ray and found the fracture. So again, a negative X-ray doesn't suggest that, it doesn't rule out the possibility of a fracture being present. Transverse ligament incompetency. Now, as I say, you don't get torn transverse ligaments with trauma. They tear as part, or isolated tears them. They tear as part of the dens fracture if they're going to tear. But you can get instability here, and this is particularly so with hospitalization of C1. So you get extra stress on this with movement, and then it will stretch out the ligament. And of course, there is the articular ligamentous type of instability due to the systemic diseases where the joints become degenerated and you get more play in this. Flexion extension X-ray and left is neutral. You can see with flexion, the atlas moves forwards and away from the axis. So you see that space between the anterior arch of atlas and the dens. This is the atlantodensal interval, and it's an important measurement. So this should stay together. There is no such thing as a normal amount of separation here. I know people talk about 3 millimeters, but this shouldn't separate at all. At 3 millimeters is below the threshold for surgery. Anything over 3 millimeters seems to be fair game for surgery, and they'll basically fuse these two together. With a normal sized canal, and this will come up later when we look at assessment, with a normal sized spinal canal, you need 8 millimeters of separation, of migration of the atlas forward before the cord even starts to become compressed. So anything under 8 millimeters with a normal canal, you won't get neurological symptoms or signs. Okay, so this is a normal X-ray for flexion extension, and it was on this one that the sensitivity and specificity numbers of sharp pursers were made by Udlig and Enderborn, and we'll talk about those when we look at assessment. So these are X-rays of a dens fracture, and there are three types. One bit goes through the, knocks part of the tip off, one bit goes through the neck or the base of the dens, and the other one actually goes through the body. Of the three, the one going through the neck is, I believe, the least stable of them. But here you can see the fracture on a CT scan, the upper three pictures. Now, if you look at the bottom picture, this is the one I said on the MVA video that I couldn't see the fracture. Well, I've expanded this whole thing, and I think that might be the fracture there, but even so, I'm not sure about that. The other place it might be is in the teeth. Now, this is a problem. They can get lost in those teeth. So this X-ray is one of the reasons why this is a commonly missed fracture with X-rays. So if this is negative, what should be done is, if the history is such that a fracture is possible, not even likely, but possible, they should have a CT scan to make sure. But they're not the easiest thing to spot sometimes. So there's your fracture. And then there is the ARF on the left. So you can see how it's rotated around, and it's shifted over, and it shifts away from the arch of atlas a little bit. And the lad at the bottom there is showing the torticollis. Now this can obviously be much worse than that. And they grade this in 4 types of increasing severity and increasing encroachment onto the spinal column. The 4th type is it rotates backwards rather than forwards. But this is a fairly mild one, and you can see on the X-ray that there's no evidence of instability there, and that the dens, there's no ADI basically. The picture on the right is of os odentoideum, and whether this is post-traumatic or not is open to debate. And you can see the ossicle sitting forward there. Obviously, the pathology is much more complex than that, but I think that will do for a review, to be honest with you. So next part of this will be assessment.